Hey everybody, it's Dr. Eric Balkams. We're back for another edition of Thyroid Answers podcast. Today, I have Dr. Kelly Halderman. Dr. Kelly, welcome back to the Thyroid Answers podcast.
Thank you, Dr. Eric. Always a pleasure.
Well, thank you for saying that. And guess what? Today, you are not asking me a bunch of questions. Today, I'm going to ask you a bunch of questions because we're going to talk about something called the Low Fodmap Diet. We're going to talk about what it is, why it might be beneficial for some people, and maybe some pros, the cons, and we'll kind of get into it a little bit. All right?
All right.
So can you, before we get into it, some people may know, some people may not know. I know everybody knows who Dr. Kelly Halderman is, but some people may not. So can you give some people a little bit about your background? Who's Dr. Kelly Halderman? Who is she? Why should we listen to her?
So the infamous, right? I am Dr. Kelly Halderman. I have been on this podcast multiple times, so people can just fast forward, my background. But I was trained as a traditional medical doctor in family practice, was humming along, loving that until I got sick myself. Did not have the tools in my toolkit to get better from the illnesses I was facing. And so I went and got a naturopathic medical degree. And so I have a PhD in clinical nutrition, a medical doctorate. I'm pointing to all the degrees behind me, and I'm a certified clinical nutritionist. I believe that, medicine has its purpose. Allopathic medicine's amazing, but for most of the things that we have going on, diseases, especially in a country where we have access to good food and good water and things, I believe that nutrition is really how. It's one of the foundations of how we really must really take seriously. And so I use that in my practice. I also love genetics. And, kind of what the topic today is that I'm a speaker for a lot of different associations. And I'm doing a talk on neuroinflammation and microglial activation. And so I was researching that and really looking into some of the strategies that we can use as practitioners to help people get their guts right? I mean, like you and I, we're constantly working on our guts. Like we're working on GI health. We're working on to nourish the gut, eat the right foods. That's just part of the plan. That's just part of, you never really give up on that. And so I stumbled across a lot of really great literature on butyrate. And the studies about healing the blood-brain barrier, healing the epithelial lining of the GI system. And I'm like, yay, butyrate. And so first and foremost, I always look toward foods. What foods can we consume that are high in butyrate? And lo and behold, those foods, which are prebiotics, are really high in FODMAPs. And I thought to myself, I actually am certified as a FODMAP practitioner. And this was really a really helpful tool to have in my toolkit. And I thought, let's talk to Dr. Eric. Have you explored this? Are you using it? So I thought we would kind of jump into learning more about this, what FODMAPs are, what a low FODMAP diet is, and who it applies to.
Yep, perfect. So let's do this. Let's back up a second because you used a couple terms I don't think everybody knows. Okay. One of those was you talked about glial cells, right? Mm-hmm. So tell people what glial cells are and why it's important maybe to know what those are.
Sure. So in your brain, you have neurons, but you also have supporting cells. And one of those cell types are called microglial. They're actually like the macrophage, the eater they're part of the immune system. So let's start there. Like they're part of your immune system. Their job is to phagocytose, so eat pathogens and things that aren't supposed to be there, right? So when the microglial cell gets activated, so there's two different phenotypic states. It's like Jekyll and Hyde of the macrophage, right? So a macrophage in its M2 state is nice and happy, and it's promoting neurogenesis. It's promoting like your brain is in a really nice anti-inflammatory state. And however, the Mr. Hyde, which is ever the bad one. So the M1 state can get set off by lipopolysaccharides, so that's bad gut, can get set off by pathogens and things that are not supposed to be in the brain. And so in this M1 state, your cells in your brain that are very, very numerous, they're protecting the neurons. What happens is they get very inflammatory. We call it brain on fire, right? So these cells are spewing out cytokines, spewing out all kinds of inflammatory components through the NOx enzyme. So the NOx enzyme, NADPH oxide, is a brilliant maker of superoxide. So that's a free radical. So how does this manifest in someone? Well, it can be brain fog, which is really common. It can be just cognitive issues. It can be sleep issues. It can be mood disorders. So that's what a microglial cell is. And once it gets activated, it's very hard to turn it off. It's very hard, actually, to get it back into its M2 state.
Okay. So we've got their immune cells. Microglial cells are immune cells. They're like other, when you look on your CBC and differential, if your doctor runs it, you see neutrophils, you see monocytes. So it's like a monocyte just in the brain, right? Okay, good. And so it can be in a kind of easy flowing anti-inflammatory phase, and that's called the M2 stage. And it could be in the inflammatory, hey, I'm looking for a problem stage, right? Ready for a fight stage. And that's the M1 stage, right? And so if you have a lot of microglial cells in an M1 stage, you're going to have more inflammation, right? And so that can be a normal response, though, to some type of stressor, some type of injury, some type of
injury,
organism, threat, or whatever, right? You can get those cells upregulated, and they may stay upregulated, cause a lot of symptoms. And it may be because the thing is still there that caused it, or it could be like we see in the immune system. Sometimes the immune system kind of gets plasticized in a direction, like it gets kind of stuck in a certain position, right? But I would say for a lot of people, it may be because the underlying mechanisms sometimes are still there. Because unless you're doing functional medicine to reduce the triggers, once inflamed, what's turning it off if the triggers are still there, right?
Right. And those M1 cells, when they're turned on, they are actually destroying the blood-brain barrier. So it's like a double whammy. And there's not a whole lot. And like you said, functional medicine, we remove the insults. We go in, we look at the root causes. And then after, if your house is on fire, you put out the fire, you start to look at repairing. So I found that butyrate was a nutrient in the literature that was helpful at repairing the blood-brain barrier. And there's a lot of different nutraceuticals that can help quell those M1s down as well. So, you have your polyphenols, you want to scavenge your superoxide. So using SOD, there's a lot of things, and that can be a whole other podcast, but that's kind of like, we got to get
You're doing good. Right. I just want to I'm going to just steer you a little bit because I think we're a little premature there, but because you mentioned the gut, and somebody might be going, okay, wait a minute. She's talking about the gut, and then she's talking about the brain and the glial cells. What's the connection between, why are you talking about IBS and a FODMAP diet if we're talking about the brain being inflamed, right? So what's the connection there between the gut and the brain, and why are we worried about the gut if we're talking about brain-based inflammation?
These are such great questions, Eric. I think I have to literally back up with you, and I'm glad you're catching me as I'm going off in my rabbit hole. Let's bring it on back and make some sense here. So there's this thing, and it's called the gut-brain connection. And we think of this in terms of a two-way street, right? So the brain's communicating with the gut, and the gut's communicating with the brain via the vagus nerve and other neuroendocrine and endocrine signaling. But the problem is that I just gave a little bit of a preview of this, is that when the gut is not working, when the gut is inflamed, when we have dysbiosis, when you have leaky gut or whatnot, there's usually a production of lipopolysaccharides, right? By the gram-negative bacteria. The lipopolysaccharide can travel to your brain, and it is extremely inflammatory, and it turns the nice M2s into M1s. So if you don't stop spewing out lipopolysaccharide from your gut, whether you're, drinking alcohol, you're consuming glyphosate, you're just literally not protecting your gut. And boy, they did that study in college students where they had a group of them come in and they didn't have any GI symptoms. They had no medical diagnosis, no symptoms. And they measured their gut function and they found upwards of 65, 75%, I'll find the study, that actually had pretty significant dysbiosis and were actually producing lipopolysaccharides. So you don't really have to have some sort of terrible, debilitating symptom in order for your gut to be really struggling. And I think that's important point is that, I always talk about my teenagers. I kind of pick on them, but, they think that they can just eat all this junk food and, all this high fructose corn syrup and all this, and that, well, Mom, I'm totally fine. But I have done functional medicine testing on my middle teenage son, and his gut is not fine. It is not fine. And so that lipopolysaccharide is all over the body. And it also shuts down phase 2.5 detoxification. So we can't even move our bile. We can't even have the normal detoxification, and it will catch up with you if you leave it.
So we have organisms that live in our gut naturally, right?
Yep.
Lots of bacteria live in there. Some are gram negative, some are gram positive. There can be a bunch of other organisms in there, but of the bacterial content, we typically talk about gram negative, gram positives as the basis, right? Republicans and Democrats. And you need both of them to kind of weigh each other out. The gram negative bacteria, part of their covering is this lipopolysaccharide coating, right? The gram positive bacteria have something called LTA, I believe, versus LPS, which is the lipopolysaccharide is gram negative, LTA. And it's the pieces or these fragments of the organism that can break off and get into the lymph, get into the bloodstream. And it's not as big of a deal if these bacteria are breaking down in the gut and they're going to kind of get washed out through the poop. But when these lipopolysaccharides get into the body proper, cross the barrier, get into the body proper, then these are what we call PAMPs, pathogen-associated molecular proteins. And these things float around into the bloodstream, and they can bind to immune cells and say, hey, this thing's in the body, it's creating a problem. That can activate an immune system. It can be the thing that if it binds to a macrophage, a microglial cell, that the microglial cell will say, whoa, somebody's breaking in here. We've got these toxins in the system. Look out. Everybody, create some inflammatory chemicals to try and to kill that thing. The problem is the immune system may not be fully aware of where it's coming from, but if you're getting those lipopolysaccharides into the brain, it's trying to address those and knock it down. But the byproduct of it is toxic chemicals that are designed to kill an organism, but it can also damage our own tissue. Is that fair?
Oh, yeah, absolutely.
So, and you also said there's a connection between the brain and the gut. And we've known this, we call this brain one, right? The one that sits on top of our shoulders. And then we call our gut brain two, and they're in constant communication. And I think more communication than people realize, because the gut bacteria that you're growing produces hormones and neurotransmitters and things that your brain needs. You were talking about the importance of butyrate, which is really generated from the gut flora, but only if you have the right gut flora. So what you feed the body, right, really does have an impact on what type of organisms grow in the GI tract. And then that can have an impact on what happens out in the body proper, what happens in the brain. So if you're growing bacteria on crappy food that's then creating more toxins, you're going to absorb more toxins into the system. You may not produce the appropriate or the right amount of neurotransmitters that make you feel happy. And instead, you may produce more neurotransmitters that make you more edgy, more anxious, more depressed. Is that fair?
Oh, yeah. Spot on.
Awesome. So when somebody has a brain-based problem, aside from the fact, unless we know that they just had immediate trauma, obviously it's a different situation. But even trauma from a while ago can dysregulate the brain and dysregulate the gut and then create a loop. But for a lot of people who have brain fog and fatigue and anxiety and depression, it's fair to say that those issues, regardless of GI symptoms or not, could stem from problems in the GI tract. Yeah. Right?
Yeah.
And so whether they have thyroiditis, they have some other identified autoimmune condition, or they just have chronic immune issues that they don't have antibodies for, which is a possibility, or they have chronic inflammation, all looking at the gut and what goes on in the gut is a great place to start trying to help somebody who's got chronic health issues. Fair?
Absolutely.
All right. So then as a physician yourself, you are, one of the things that you might do with somebody when they first come to see you is look at their diet and try and modify it, right? And so one of the big diets in kind of the functional medicine world is to put somebody on an autoimmune paleo diet. That's one of kind of basic 101, right? How is that diet? When would you say, okay, that's not working, maybe I should try this thing called a FODMAP diet? And what does that even mean to the general lay person? What's FODMAP, right?
Yeah, it meant nothing to me about 5 years ago. So, luckily I took the whole entire certification program. So I would say step one is an autoimmune type diet, right? Autoimmune paleo, a paleo, you kind of have to meet the person where they're at. So let's get as away from the frankenfood as much as possible. And let's get into a whole food diet, and then let's level up and let's remove the grains. So then we're going to go paleo. So I just meet people where they're at. I'm like, you want to go all the way to autoimmune paleo? Well, here's Nikki Trescott's book, cookbook, right? This is a great place if you can start there. So we kind of level up to see. But when I hit a plateau with a person where they're on the autoimmune paleo and they are not, they're not doing very well, right? They're doing everything right. I will have them do an elimination diet. We've talked about that in the past. That's the gold standard. Elimination diets, guys, hands down, you will learn so much about your individual biochemistry. That is a great place to go. So then if I'm just running into walls with their treatment I will try and see if they would like to learn about a low FODMAP diet. So, again, by definition, what is even the FODMAP stand for? So it's an acronym. So it stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Okay. Really big mouthful with what it stands for.
You know where I'm going. If I'm a person who heard that for the first time, what does that mean, fermentable? What is oligosaccharide? What is disaccharide, monosaccharide, and poly? What does that all mean to me as the general person, right?
Okay. So FODMAPs in general are a group of sugars. Okay. So not like table sugar, but just a group of sugars by definition. This word saccharide means sugar that are not completely digested or absorbed by our intestines. So when the FODMAP reaches the small intestine, they move really slowly and they attract water in with them. And then when they get to the large intestine, the FODMAPs are fermented. So, if you think of fermented foods like kombucha, if you open up the top, all that gas pops out. Or you have to be careful with things that are fermented. I've never done this myself, but making sauerkraut, if you're really careful about what you're doing, else you can basically poison yourself. But gases are normally produced when things ferment. And so what happens is the gut bacteria ferments these FODMAPs, and then the person gets a lot of gas. And so then that extra gas, the water retention causes the intestinal wall to stretch and expand. And so, when the Monash University, who I did my training with, when they studied this diet, they studied it specifically in those people with the diagnosis of IBS, so irritable bowel syndrome. And it's really common. It's diagnosed in 1 in 7 people. So that's a lot. So, again, it's a diagnosis, a medical diagnosis. It's chronic relapsing symptoms like abdominal pain and discomfort, bloating, distension, and diarrhea, constipation. But the key in this one is there's no abdominal pathology. So, we never want to replace any of this information on this podcast with good medical care. So what I'm saying is that if you have any red flags, bleeding, because this symptoms like these could be IBS, they can be a food allergy, they can be a lot of different things, but they could be bowel cancer, they could be endometriosis, they could be ulcerative colitis or Crohn's. So make sure that you're talking with your doctor about this. But the Monash University did a lot of studies in the people, clinical studies in people with IBS. So there's a lot of gray to this, and that, Dr. Eric. It's like, that's what I don't like about medicine, quite frankly, is we're black and we're white. Either you have diabetes or you're fine. It's like, no, or you have MS or you have not. It's like there's a lot of gray zone in there where this low FODMAP diet was studied in people with IBS, but certainly some people are sensitive to the foods that are high in FODMAPs. Now, let me just say this. And they even have it on, in the information on the Monash University, is that it's almost impossible to memorize all the different, what's high FODMAP, what's low FODMAP. I was tested on it, but it's a matter of, they make it very easy if you'd want to try it, learn more about it, is they have an app for it. And so I'll give you an example. So high FODMAP foods under fruits. High FODMAP foods are apples, cherries, dried fruit, mangoes, peaches, pears, nectarines, and watermelon. Low FODMAPs are grapes, cantaloupes, pineapples, and strawberries. So a person, if they're like, well, I still want to eat fruit, you just make these transitions. You make these transitions over into these lower FODMAP diets, and it's usually about 2 to 6 weeks that you're on this. So I don't think I gave justice to answering your original question. So FODMAPs: fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So again, fermentable meaning process through which the gut bacteria ferment undigested carbohydrates, and then that gets that gas, right? The oligosaccharides would be fructans and what's called OGSs, found in wheat and rye and garlic and legumes. Disaccharides are found in like milk and cheese and yogurts. And monosaccharides is fructose, like your honey or apples. And then polyols is actually sorbitol and mannitol, which is more your artificial sweeteners. So I know some people who cannot tolerate at all any artificial sweeteners, and that's one of my questions I ask. Can you use like the sorbitol, or I think some the replacements for sugar? And like, no, I get so much bloating and gas, and that's kind of a tip off.
Okay, so if we think about this is something, if you're having a lot of GI symptoms and nobody's identified a pathology yet, you've got constipation, gas, bloating, maybe loose stools. I mean, they've taken this. IBS is like a throwaway diagnosis. Right?
It is. Yeah.
And so you could have IBS-C, which is constipation. You can have IBS-D, which means you have a lot of diarrhea. And you can have like an IBS-M, which is like a mix, right? And so essentially, I think the Rome guidelines tell a physician, if the patient has these types of signs and symptoms, test them for pathology, right? If they don't have pathology, then they have a functional GI disorder, and we're going to call that irritable bowel syndrome. And then you treat their symptoms, and what should be done is a follow-up pathology test should be done the following year to see if any pathology developed. And it's kind of, you keep treating symptoms, keep testing for pathology, keep managing symptoms until eventually either it self-corrects or you develop a pathology, right? And I think that's the summary of the Rome guidelines, right?
Right.
And so the interesting thing there could something be wrong, but not pathologic yet?
Yeah.
Yeah. So they call it a functional GI disorder, but they don't typically run a functional GI assessment in allopathic medicine. Is that fair to say?
Fair enough.
So there are some companies out there that actually do functional assessments of the GI tract, which we use in functional medicine to be able to look at, do I have appropriate acid production, enzyme production, bile flow? Do I have malabsorption issues, poor digestion issues? What type of bacteria is growing? Too much, too little? Do I have other organisms that are growing? And so for the person who gets diagnosed with an IBS condition by an allopathic physician, they're doing what they're supposed to do based on their guidelines, which is to look for pathology, but they don't really have a system in place other than to identify that you have some type of functional disorder, but they don't do functional tests. So if sometimes I have patients come to see me, you may too, who say, I went to see a gastroenterologist and they said there's nothing wrong, I just have IBS, which is like, okay, wait a minute. You don't have pathology, but you wouldn't get a diagnosis of IBS if there wasn't something wrong, right?
Right.
And so that means now that leads to the next question, which is, what's the problem here, right? Is it the biome that's in there? Is it these high FODMAP foods that's the problem? Is it the terrain, right? Is it the digestive capacity? Is it lack of motility? Like, for the person, because that's what the person's saying. Okay, so is it just that I have to eat low FODMAP foods for the rest of my life? Is it the actual foods that's the problem, or is it something else?
Well, that's the jugular question, right? And I think that when the Monash University, when they studied this, when they did the 2018 meta-analysis, when they did the other study, I know that they were putting people on this low FODMAP diet, and there's levels of it. So there's very strict, and then you can ease up, and then you get to where you can dip back into some high FODMAP foods. You just kind of watch yourself. So was that changing the terrain? Was giving that, that all the gas and the fermentation, was that a part of it? Is that cleaning that up enabled the microbiome to get more healthy? We didn't study that. We can postulate that that's probably what happened, because it makes more sense to think that there's more than just, like, the question is why? Like, why is this person? And we don't have a good answer. So what are your thoughts on that?
Yeah, I think it's a combination of factors, right? So it is by the time the person has this diagnosis or has these symptoms, they probably have a gut biome that's been changed from what it maybe used to be when they were asymptomatic, right? Based on what we eat, the stress of our life, the alcohol, the inflammatory stuff we do, the toxicity, all of those things, disrupted sleep patterns, change the bacteria and the organisms have a tendency to grow. So that's part one. So doing whatever you feed into the gut is going to change the gut biome, right? So yeah, part of it is you created this overgrowth of organisms. If you continue to feed them, they're going to be there and continue to create problems. So the low FODMAP diet may be beneficial because it's taking away the food. I often use the analogy, if I have a man shed in my backyard with a big bar, a big screen TV, nice, big pool table, dartboard, and real comfortable chairs, and I keep it unlocked, should I be surprised that the neighborhood kids hang out there? Probably not, right? And so if you continue to eat foods that are going to grow a certain type of bacteria, and that type of bacteria creates the symptoms, part of it is the food. So you have to make that, but that may not be enough to create long-term change. It may be great when you're doing it, right? But if you still have low stomach acid production and bacteria coming from your food and your oral cavity is coming in and overgrowing, that may be a problem. If you have low bile flow coming into the GI tract, then you're not killing off some of that bacteria. If you don't have appropriate digestive enzyme and bile capacity, then you're not breaking the foods down, right? And so now you're getting more undigested food that's making it into further down into the GI tract. That creates a problem, right? So it's part of it. It is the food. Part of it is the terrain, the secretory IgA. What about the immune system? Shouldn't the immune system be there and kind of helping manage some of this stuff? So I think it's a combination of factors that really become important. And this is a tool that if you've done it in autoimmune paleo protocol and that hasn't seemed to work, this may be a tool that changes the GI tract a little bit more, or changes the food coming in, that then allows for some change in the bacterial content. But then we need to say, okay, what else can I do to help restore a more balanced or diverse biome so I don't have these things occur again?
Right, and it's stated that the low FODMAPs is not a cure for IBS. It says on, in the literature, it's makes it more manageable. So, like what you're saying is that get a good functional assessment of your gut health to know really what everything is driving it. But again, like I've had people where there's just, they're just still having issues. And what tipped me off too was that the fiber was just killing them, like any sort of fiber that they were having. So I switched them to sun fiber, and that is partially hydrogenated guar gum, which is low FODMAP completely. That's really what got my training started, is being interested in that. And they have no problem with that. So again, maybe just taking away the more of the ferment, and it starts with uncovering the layers, getting a good assessment, and knowing what's going on.
Yeah, so it's one of the things I want to make sure that the listeners get is, because I did a gluten-free diet and it helped for a while, but then I'm not better, right? I did a AIP and it didn't work for me, and then it didn't. And then I did a low FODMAP and it worked for a while and then it didn't. Making the dietary change is really important. And you may have to make lots of dietary changes along the way. And the low FODMAPs is a tool to help create change and then help in the process, but it may not be like this is the thing that's going to fix the situation, because it can change maybe the level of inflammation, it can change the type of gut flora. But if the real issues, weakened secretory IgA system, lack of digestive capacity, lack of an immune system there, if you do a low FODMAPs diet and then reintroduce high FODMAPs food with the same terrain, the same environment, what's likely to grow back? Maybe the same stuff, right? So we have this low FODMAPs diet. If somebody's going to try it, how long do they do it for? Like, what's the recommendation?
I recommend 2 to 6 weeks. And they do also recommend working with a FODMAP certified practitioner. So if you just type into Google Monash University FODMAPs, you really can't miss it. Like, that's the only place that they certify this. However, it's like we were talking before the podcast started. It's pretty, if you use an app, they have a really nice app, and I believe it's free, or it's visit $5.99 now. It's somewhere very reasonable, but like $5 and free, but that you can manage to do this with no harm done, right? You can switch over from it, I'm going to eat an apple, to I'm going to have a strawberry, or whatnot. It's pretty simple to make these dietary changes. Put rubber to the road, as we do a lot, and see if it works, see if it helps. See, it's a clue. It's a really big clue, like something not going on, not right there. So I think that it's really pretty a low risk thing. Of course, discuss it with your doctor, discuss it with whomever your care is through, because maybe there's some reason that you shouldn't. I can't think of one, but we all like to cover
I mean, we have to
ourselves.
say those things so that somebody says, well, they told me what to do. But I think this is one of those things that if you're saying, hey, I'm going to try gluten-free, how do I do? I'm going to try dairy-free, how do I do? I'm going to try this low FODMAPs. The best thing that you can do, if you do it and everything goes away and you can go back to normal, that is awesome. Not very common, but it's a tool. But it's a great thing to tell your practitioner to say, hey, when I tinkered with this, here's what I noticed. Then they may be able to say, okay, that steers me in this direction, right? It steers me in that direction where they need to look. What would be the things that we talked about, some of the symptoms, gas and bloating and loose stools or constipation, but what would be some other things that you might look for besides the kind of the sugar, alcohol, the alcohol thing that you talked about, these artificial things, maybe them telling you some of this? Is there any like things that go ding, ding, ding in your head, like this is a patient that I better try that low FODMAPs on?
Well, the disaccharides, so the D in FODMAPs, when they say that with the dairy products, milk, soft cheeses, yogurts, there are some that are okay, but in general, if someone's eating dairy, they're not really hand cherry picking the low FODMAP ones. So that'll kind of be a tip off for me that maybe it's not just lactose intolerance, or maybe there's something else going on here where they should actually try and move toward the low FODMAP dairy choices. That's kind of like one of the tip offs. The other one is that I've done the gluten-free diet and it didn't help me. It's sort of like that gray zone where they can't quite figure it out. Some of the gluten containing foods, some are low FODMAP, some are high. And so they actually commented when they were studying this is that the reason why a lot of people benefit from going gluten-free is because it's actually a high FODMAP and they're taking out the FODMAP. And if they would have taken out a high FODMAP dairy and the high FODMAP fruits and vegetables, that would have catapulted them, because the studies show that 1 in 4 people who did this diet really saw, with a diagnosis of IBS though, they really saw an improvement, a big improvement. So I thought that was kind of interesting too.
Yeah, so I think it's like a tool to use. So if you've done AIP, if you've tried some of the other options of diets, you're just like, nothing seems to really resonate with me. Even before maybe you go, because there's some other things to consider that maybe we can talk about here, but maybe before you look at maybe food reactivity testing or loss of tolerance testing, you could try a low FODMAPs diet and see if that creates a benefit for you, because it really doesn't cost much to do it, right? I mean, it's
100%. Yeah, and I misspoke. It's actually 3 out of 4 people who got a benefit, not 1 out of 4 with the IBS. So that's a big difference. It's 3 out of 4 people who did the diet who had some form of IBS. So again, that junk diagnosis of bloating, constipation, diarrhea, they did have a response. And I love what you just said. It's before you go do high level blood testing and things that aren't the most reliable anyway, we could say it's worth a shot.
Yeah. So because it is, if it's free, essentially all it is a swap in foods, then you can start working on making some of those swaps. If it works, that's awesome. Then you know that, hey, it's probably an imbalance between the bacteria and the foods I'm eating. I change the foods, I change the bacteria, and then you can start. That's great information for the physician, and for you, it should give you some insight like, hey, there's a problem in there. It seems to be related to some of the food. That's great information that you may not have the skill set to address on your own, but it's great information to take to a functional medicine practitioner and say, hey, I got these symptoms. This is the diagnosis. I tried this diet I found, and I felt a lot better. And if they have some knowledge of the low FODMAPs diet, that's going to lead them in a certain direction. it may help you maybe even without doing testing, or maybe they want to do a functional GI assessment based on that to get a better understanding of what's happening within the GI tract. Good. I like that was good information. So I guess when that doesn't work, we can touch on it for a moment, which is, all right, what if I do a low FODMAP diet? And I don't know, some of the low FODMAP foods bug me, some don't. Like, what do you do then? I'm sure you've had those clients who do that. Yes.
So I have, where then I think that there's truly an IgG or an IgA. I actually uncovered an IgA to corn, and it was just giving this person headaches. And so when they were doing the FODMAP, then it actually, my clinical brain was like, well, there's something else. So it's not easy, right? Stuff is not easy. So it's like layering, and then your clinical experience, and then listening to the patient. Food diaries are super important. Sometimes people we don't even know why, but they just can't eat a particular food. So, they just can't do it, and we don't know why. And so we just take it out and we carry on our merry way, and there's nothing that we can do about it.
Yeah. And so there's other thing we talk about, leaky gut, right? And for a lot of people, when they eat foods, and this is where it really gets confusing, and it gets like nothing seems to work for me. In those cases, that's one of those times that, hey, it's time to run some IgA testing. Yep. I use a lot of Cyrex's labs for that. And you find some really interesting things, and you're saying, okay, but the part of the problem is maybe some of these foods that are AIP approved, right? You're reacting to. You've lost tolerance to them. Maybe there's some foods on this low FODMAP diet that you still have lost tolerance to. And so now, even though it's a healthy food, even though it's on AIP, even though it's on low FODMAPs, if you've lost tolerance to that food, it's still going to potentially create a problem. So maybe we should talk about that. What does that even mean? Right.
And talk about molecular mimicry.
Yeah. So
another problem.
For, I guess, loss of tolerance. Do you want to explain? You want me to explain?
Yeah, why don't you're really good at that. You got that down.
So for people, when you go, what does that mean? I've lost tolerance to it, right? I think the best thing to think about is your friends or family, right? There's people that come into your life every day and you go, I love that person. And they make you feel good and happy. And that's great, right? So you really tolerate those people. And then there's people in your life that you give them or take them, right? If they're not around, it's no big deal. If they're around, they don't do much, but it's no problem, right? If you could take them or leave them, it's no big deal. You tolerate them, right? And then there's people that you just can't stand. Family member, friend, ex-friend, your ex-husband or your ex-spouse, right? Whatever, or your ex-in-law, right? And you're like, when you see them, you just want to put them through, like, get that person out of here. Like, it changes your demeanor. You're angry, you're irritable. You want to get in a fight, right? That's loss of tolerance. And so for foods, our body is established. So when we start eating foods, the food shouldn't really elicit a loss of tolerance response. If we have good digestion, once we get it in there, the first time, maybe the body's like, hey, what the heck is that? That's a new thing. What is that? Is that problematic? And then we go, okay, it's coming in. It's not creating a problem. And we get tolerance for that food. But there occasionally, we start to lose tolerance. So how does that happen? That the immune system or the body gets angry and irritated and mounts an inflammatory response when we eat a certain food. Well, we have foods, and all foods have proteins, right? And the proteins break down into smaller chunks, which are called peptides. And then the peptides break down into smaller chunks we call amino acids. And the amino acids are the thing we really want to absorb through our cells to get in, because now these little amino acids, we can absorb them, bring them into the body, and then give them to the cells to make new peptides and new proteins and new enzymes and new hormones. But if we have food that doesn't get broken down appropriately, and if I say any of this wrong, Kelly, make sure you correct me, right? So we have these undigested proteins that now break it down into peptide, but now that peptide piece doesn't get broken down any further. And we have these cells in our intestines, and they're only like one cell thick, and there's little junctions that hold them together. We call them tight junctions. And when we have these peptides, sometimes just naturally they can get through the tight junction, and other times the tight junction is damaged, and now there's a big gap that things can go through. And so anytime there's too much peptide, this undigested piece getting across that barrier, now the immune system's on the other side of that cell, and it's saying, hey, wait a sec. It's like the bouncer inside the club. Like, hey, how did you get in here? You're not 21, right? And so now it says, hey, this guy, this thing, this peptide, this is no good. It's in here. It's creating problems. And then it makes antibodies, a little police force for the immune system that says, hey, next time you see this thing, you go after it and get rid of it, break it down, get rid of it. And so once that occurs, now we can start have a reactivity to food. Now, what foods is it? It could be any food that's poorly digested that crosses the barrier, and the immune system says, hey, that's problematic. There's one other thing that can happen as that occurs, is that if there's something else, a toxin, an organism, or a fragment of something like that lipopolysaccharide thing you were talking about that gets through that barrier, and that lipopolysaccharide binds to that piece of peptide, now that might initiate an immune response. Like, hey, I knew what that bacteria piece was, and I knew what that peptide was, and maybe I was okay with it, I was tolerant of it, but now this new thing, I don't know what the heck that is, and now I'm going to make an antibody. Or something some peptide structure that we've previously identified as potentially problematic. This new piece of undigested food protein leaks to it, and it looks pretty similar. And now the immune system says, man, that peptide looks a lot like that peptide. Now we're going to start reacting against that too. And that is, I tell my clients, it's like dating identical twins, right? Once you're at a club, they dress the same that night, they go into the bathroom, one comes out, now it's dark, you've had too many drinks, and they look identical, and you kiss the wrong sibling, like, is it really your fault? And, when the immune system is chronically activated, or you have a really weak system, you can have a tendency to have mistaken identity and start to trigger these things.
Right.
Is that close enough?
That's spot on, yes.
So you talked about, and why that's really important, why it ties together with thyroid physiology, is there are undigested peptides that can have a similar sequence as parts of our tissue. So when our tissues break down, which they always do, and if there's a similar amino acid sequence to this peptide that we've lost tolerance to, that antibody is floating around in the circulation, and it sees that piece of tissue. Now it says, hey, I'm going after that. And it could then create damage to tissue when it really shouldn't do it, because our body should know who we are and who self is. But then we can get this cross-reactivity or molecular mimicry. It looks similar, and now I'm going to react against that, right?
And that can happen against, like you said, thyroid tissue, your myelin sheath. So MS, that can be caused by that too. So it's tricky.
And interestingly for people, so you do these things, and what you find is, well, I'm eating this food and it's healthy, but you're producing antibodies against it. You've lost tolerance. So I can't eat it? No, you really cannot eat it, because if that food that food peptide that your body's produced antibodies against looks like something in your body, it could cause damage to the tissue. You brought up corn, and so this is a really good example. There are things that are called aquaporins, and we talk about those when we taught about detoxification and bile flow. We talked about aquaporins in the class we talked, right? And those are the water channel proteins. So, and this has happened for a number of my clients who go on a gluten-free diet, They do the AIP, they're doing good. Now they're reintroducing foods and they can't figure out what's going on. And I've had a couple clients that said, my brain fog is back and I can't figure out what it is. I think it's food related, but I can't figure out what it is. All my brain fog, memory issues, they're coming back. What is it? Mm-hmm. And when you do some of this antibody tests, and Cyrex has tests for aquaporins, and they're positive for aquaporins. So the plant, the corn, the tomato, the spinach, the soy has these water channel proteins in it. So somebody could be doing like the perfect thing. Right. I'm not eating my lectins. I took the skin off the tomato. I got rid of all the seeds, and they think they're doing a great job. And yet that's not the part that they were probably reacting to. So these plants have aquaporins. So if we've lost tolerance to the aquaporin, this water channel protein in the plant, and now you eat that, your body's going to react against that water channel protein when it's in the gut. But it also then produces antibodies that go into circulation. And we have aquaporins in our own body. Mm-hmm. And now those antibodies can attack our aquaporins, which look very similar to the aquaporins in the spinach and the corn and the tomato. And now those antibodies start damaging blood-brain barrier. They can start creating damage in the brain where there's lots of aquaporins or other tissues that have them. And it's little things like that you go, oh crap, this could be way more complicated than going gluten-free, right? Or going, hey, why is this everybody says low FODMAP works. Well, maybe it may work for a lot of people, but when it doesn't, or an AIP or something else doesn't work well, you've done a lot of things, it may be because you've had years or decades of leaky gut and poor digestion that you've lost tolerance to foods. And especially if you switch, you see people really change their diet and their lifestyle, and they're like, all of a sudden I went gluten-free, now I was great, and then all of a sudden I'm having problems. That's where my brain starts going, they may never have addressed the leaky gut issue, and all these foods they're eating on an ongoing regular basis because they're technically healthy, they've lost tolerance to. And you can start to see that. Right. But that's crazy. And some of those foods, and I know on Cyrex's test, the things that they cross-react with, I think sometimes blow people's mind away a little bit. Yeah. They cross-react, like, I think it's almonds. If you've lost tolerance to almonds cross-react, or Brazil nuts cross-react, maybe both, cross-react with T3 and T4. So You look at that and you go, what? Like, you mean my immune system may damage the T3 and T4 before it even gets a chance to do anything? Yeah. Or those antibodies cross-react with insulin or islet cell or pancreatic beta cell cells. And so now you're damaging the pancreas, or you're reducing the ability for insulin to work because of antibodies to your own tissues through this molecular mimicry. And this is the crazy stuff that, that it takes somebody who does functional medicine. We want to give people easy answers, but unfortunately it can get really uneasy, really complex, really quick, right? Have you seen similar types of things?
Oh, absolutely. Absolutely. I sometimes, the aquaporin was pretty new to me. I mean, it's not something that I knew of maybe 5 years ago, but then I'd have these people who'd go carnivore and they would do amazing. And lo and behold, like I've had to like track back with the labs and things, and it was like, well, it was probably the aquaporins, right? It can be so cumbersome and so many different ways to look at it. But so again, we want to give people information that they can try, but there can be so many levels to it as well.
Yeah, so it's difficult because a listener may listen to this and go like, well, I'm beyond. But here's the thing. A lot of times people say, I've done everything imaginable. I've done every possible test. And usually you've done what you've been told is a possible test. But that's where if you're struggling, we advocate a lot of times trying the low-hanging fruit stuff when the thyroid debacle comes out. I mean, that we talk about that in part 3 of the book, that, hey, these are low-hanging fruit things that you can do. You can modify your diet. You can work on your breathing. You can work on your respiration. You can work on your mindset. You can do these things. They're all relatively inexpensive and free and don't require anybody else. But if those things aren't working, for sure, there's a level of complexity here that the more skilled a practitioner you find, the deeper they can look, and you can find out that, oh, that general chemistry panel that I had done that I thought was really complete, that's not very comprehensive. Or the GI test that they did for a few pathogens and a few parasites, oh, that wasn't a functional GI test? No, that was not. Right? The biopsy I did was normal, so I'm normal. No. That means you may not have any pathology, but you have dysfunction, and that's what we should be doing in functional medicine.
That's right. And that's why, these podcasts are so invaluable, because we are constantly learning new things. We're constantly vetting things, talking to each other about tests, talking to each other about results and things. And so it's like, you have enough to do in a day to try and just like get through the day at this point. So it's like, I like to listen to podcasts like this because then it opens up other things that I can do, more tools in the toolkit, right? More things that we can do to help ourselves. And again, the low-hanging fruit, by definition, it's easy. It may not be the easiest, but it's something that you can do relatively cheap. And that's why we really talked about FODMAP, low FODMAP. It's really pretty simple to just make swaps and see how you do.
Yeah. And I think the other thing to make sure is, if you're going to do these things, be really aware and conscious and pay a lot of attention to what you notice, because you may like, I don't know if I feel any better. But I think what it can be helpful for somebody is maybe list out what your biggest complaints are. I have brain fog. I have insomnia. I have bloating. I have constipation, right? List those out and scale them 0 to 10, right? So that 10 is terrible, 0 is I haven't had it. Like, I have my clients do that. I'm sure you do that.
I do that personally every day. Every day. Like, I literally do like the interventions, and then I do like brain fog and all these things, because what do you say? What gets measured gets managed. Yeah.
So if you don't measure it, doesn't matter, right? But you can't. But like, these are things that you don't want to be doing. Hey, I'm going to do a low FODMAPs. I'm going to take this. I'm going to take that. I'm going to take this, and then be like, I don't know if it helped or not.
Right.
The best thing is, if you're going to switch to and do this low FODMAPs diet, do the low FODMAPs diet. Don't do a whole bunch of other things on top of it.
Right.
Just see what happens, right? And then you can monitor and take notes. Like, I don't know if I feel better, but if you chart, like you just said, and say, hey, my brain fog doesn't feel better, but my constipation's better.
Yeah.
Now you may be thinking, this is the thing I want to fix, and not realizing that, hey, my mood is better though, and my bowels are moving better. Like, you might be improving. The thing you're most focused on may not be improving right away, but maybe 3 or 4 other things are improving with the change of diet. And that's really important.
Absolutely.
Because these things occur over time. And so you need time to sometimes reverse the damage and for healing to occur. So really track this stuff and see what you notice. Watch an HRV. Like, if you have HRV, monitor your HRV, right? And so you could say, hey, I started this FODMAPs diet and my HRV has gone up by 5 points in the last week. That's probably a good sign that what you're doing is having a positive effect, right? Check your weight. Check your waist and hip measurements. Are they changing, right? I know everybody hates to get on the scale, but if we're talking about gas and bloating and pressure, take a simple Taylor's tape and just measure your stomach and your hips. Are they changing over the week to 2 weeks to 3 weeks? And you may say, I still have headaches and brain fog, but my waist is going down. Well, then it's probably having a positive effect, and maybe you need more help because the brain is just massively inflamed, and that's not enough to make a significant enough change yet that you notice. But if you went from, if your midsection, if your waist over the course of a week or 2 weeks drops an inch or 2 inches, you didn't lose an inch or 2 inches of belly fat, right? That was gas and bloating and pressure, right? So I think we beat this thing up pretty good.
Yeah.
Right? So anything you want to add on to low FODMAPs?
No, I think that we did a good job going through the ins and outs of it. And I think that if this piques anyone's interest, there's a lot of really good information. Again, just Google Monash, Monash University. You can look at their studies. You can look at, if you want to find a practitioner to work with, there's a lot of information on there that I think would help kind of your decision-making decision.
Okay, awesome. All right, so I got that. We should put a plug in there. We're still working on the thyroid debacle. We're trying to get it out. We're still working on it. So we'll let everybody know. We should have a bunch of things up with some more information, but it's still in process. Kelly, what about you? If people want to hear more about Kelly or hear her talk, or I'm not sure where you're at in the world of working with clients, but I know you're doing a lot of different things. So where can people hear more about you? If they want to hear you talk or lecture, where can they go?
Yeah, so if you sign up for my newsletter at drkellyhalderman.com, then I'll have your email, and then you can also email me at info@drkellyhalderman.com. I'm currently full up of clients because I travel so much and speak so much, and we're writing this book, and I am available, and that's where you can find the latest and greatest on all things me there.
All things Kelly. All things Dr. Kelly Halderman. All right. Awesome. So, Kelly, thanks so much for coming back on the podcast. For everybody who's listening to the podcast, share this one with your friends and your family for sure. If you have any questions, obviously reach out to me. You can reach out to Kelly, ask your questions, and we'll do our best to get back to you. Kelly, have a great day, great weekend, and we'll talk soon.
Thanks, you too.